Well, welcome. Good morning, everyone. Thanks for joining us. My name is Dina Costa. I'm assistant professor in the School of Nursing and chair of the IHPI Early Career Faculty Advisory Council. And we are delighted to host Dr. Grace Lin, who is an internist from UCSF and also assistant professor of medicine and health policy, and then also part of the Institute for Health Policy Studies. Grace actually completed her undergrad and her med school here at Michigan, and she's a native Michigander from Okemos, which I said that correctly, right? Yes. And her work really focuses on defining and assessing high-quality, high-value, patient-centered care. And we're just delighted to hear from Grace as part of the Emerging Scholars Exchange, which is one of the IHPI Early Career Faculty Advisory Council initiatives this past year. So please, warm welcome for Dr. Grace Lin. There's a clicker here. Okay.
Thank you very much, Dina. Thank you all for coming this morning. I'm very excited to be here. Thank you to University of Michigan and IHPI for the invitation to come and meet all of you and to share a little bit about the work that I'm doing. So as Dina said, my work focuses on trying to figure out if we're delivering high-quality, patient-centered care, and that's what I'll tell you a little bit about today. So as Dina mentioned, my medical career and interest in health policy actually started here. And in fact, when I was a fourth-year medical student, I had the opportunity to go to Washington and do a rotation in the Department of Health and Human Services in the Division of Transplantation, where at the time they were actually reviewing the final rule for organ transplantation. So that was sort of where the public gets to comment and legislators comment on how the rule is written and implemented. And so that was sort of my first time looking close up at how research influences policy. I subsequently went to Washington, St. Louis, where I did my residency training, and then on to UCSF, where I did a clinical research fellowship, and that's where I really started to develop my skills in health services research and looking at this topic. So my goal, as I mentioned, is really ensuring that patients receive high-value, evidence-based, patient-centered care. And as Dina mentioned, I'm a general internist and primary care physician by background. And really, my motivation is to improve decision-making in terms of melding the evidence base and making sure patients' voices are heard. So part of my motivation is actually personal. I always think of patients like my father, who he has coronary disease, which is partly what I'll talk about today, but he's like your worst nightmare patient, right? I mean, he is stubborn, he thinks he knows what he wants, and he doesn't listen to anybody. So when he's seeing his cardiologist will often recommend things, and he'll sort of push back. And I thought, well, this is the kind of patient that we want to make sure is getting good care. You know, that his voice is being heard because it's important, and he's just not viewed as some cranky old man who, isn't following what the doctor is recommending, which he also doesn't do that. But that's it's important that not only is his voice heard, but that physicians, and he's had some wonderful physicians, they get credit for and they're encouraged to listen to his voice and to encourage that in care, which is, I think, something that we don't always do very well at. This slide is in here just to pose the question. Patient-centered care is sort of a buzzword and has been for the last few years, but are we there yet? And you can see on your left, there's the patient in the center of two doctors who are charting, and this is one of the issues, right? So the issue is, there's studies out there that show that primary care physicians spend probably 50 to 60% of their time, documenting and on the computer, and patients often complain about this, and physicians complain about this, like, are we looking at our computer screen more than we're paying attention to the patient? And also, I think physicians also have a lot of competing interests. So there's all this evidence, and they're trying to figure out, well, the guideline is I need to make sure that my patient has, for example, breast cancer screening and colon cancer screening, and then for diabetes, their A1C is less than 7, and so there's this whole myriad of recommended care, and so when the physician's seeing the patient, that's what's going through their head, and do they have time to focus, and are they being encouraged to focus on the patient's figuring out what the patient's preference is? And on the right here we have the caption says, "When we want your opinion, we'll give it to you." And so that's sort of the traditional paternalistic model, which I think most people would agree we'd like to get away from. And what this results in is that sometimes we provide too much or too little care. And these are just some headlines about the coronary stenting in Clear Lake is a community north of San Francisco, Northern California, where they actually were doing when they looked at data in terms of number of coronary stents and cardiac stents, their proportion for their population is much higher relative to other parts of the state. So the question is, and the San Francisco Chronicle did a sort of investigation about, well, why is this? And let's go to Clear Lake and let's figure out, why is it that their rate is so much higher? Is it that their patients are sicker, or is there something else going on? And then this headline at the bottom about Medicare cataract surgery, this is actually work done by my colleague Catherine Chen from our group, where we looked at Medicare patients having cataract surgery and how many of them got preoperative testing. So specialty societies, even ophthalmological specialist societies, the guidelines say patients by and large do not need pre-op testing before cataract surgery, because cataract surgery is one of the lowest risk surgeries that you can have, and the testing almost never changes your decision to proceed with the surgery. So it doesn't change outcomes at all. So what we did was we took Medicare data from 2011, and we looked at the prevalence of preoperative testing and office visits, and did it at the individual ophthalmologist level. So here is a chart of each bar is an individual ophthalmologist, and the black bar is preoperative testing, and the blue bar is an office visit. And a couple things to notice here. So the first is that there's huge variation. So there are some ophthalmologists that don't do any, according to the guidelines, and there are some ophthalmologists who order preoperative testing in all their patients. And what it turns out is that 36% of the ophthalmologists ordered 84% of the tests. So clearly there's a group of ophthalmologists who just, for whatever reason, whether it's their protocol, whether it's, and when I say ophthalmologist here, I should qualify that by saying we used ophthalmologist as a measure in this study because we could identify them, but we understand that often they're part of a care team, and so it may be, however the patient's care team is, the ophthalmologist is sort of the center of that, and so what we found is basically that team, a small proportion of them order a lot of the tests. And so the question remains, like, why does that happen? And this is another example of the huge variation nationally. So this is from a study that we did looking at the prevalence of stress testing prior to elective stenting in patients with stable coronary disease. So this is, again, Medicare data. And the guidelines in cardiology state that if you're not having a heart attack, stenting actually doesn't, the data suggests that stenting doesn't improve your mortality, that it's primarily for symptomatic benefit, although there's some recent data that's come out that maybe the symptomatic benefit is not so great either. And that that doctors should demonstrate ischemia primarily through stress testing before proceeding. And so if you look on this map, you can see a huge variation throughout the country, and you can see anywhere from places like Fresno, California, which has a rate of 22% of their patients got a stress test before they got a stent. So pretty much the standard there is they diagnose a patient, or they think somebody has coronary disease, and they take them to cath and do a procedure without checking to see whether or not they actually have any ischemia, to Rochester, Minnesota, up there, 71%. So, a lot of people in Rochester go through that care pathway. Now, I will say that nobody knows what the right rate is, because there's a lot of patient variation. So this is not to suggest that 70% is the right rate or that 50% is the right rate, but just to understand that it's probably not 20%, and that there's a lot of and should there be this much variation? Probably not. And Ann Arbor here is somewhere in the middle at about 53%. So, we saw this and we were sort of interested in why does this happen? So we sort of were lifting the lid on this. So the slides I showed you earlier were Medicare data, which is claims data, and so you can't tell why something happened. So what we did was we went and did some focus groups with cardiologists. And what we found was really interesting. So the cardiologists told us, we know the evidence. We know that we're going to prevent the next heart attack because of lipid-lowering aspirin and ACE inhibitors, but nonetheless, that patient in our practice leaves the lab with an open artery, the best that my interventional partners can deliver. So here's a physician that's saying, look, I know what the evidence tells me, but my belief is that this is the best care. The best care is to deliver a stent to the patient, and that's what the patient's going to get. Or this other quote, which I liked, which is, yes, medical therapy is as effective as PCI, but when I see the lesion, the bottom line is that the oculostenotic reflex always wins out. And the oculostenotic reflex is a term that was coined by Eric Topol, I think, a cardiologist down at, I don't think when he's at Cleveland Clinic, from the Greek oculo meaning eye and stenotic meaning narrowing. So when I see that narrowing, that's what, I'm going to want to open that no matter what, no matter whether I understand and I believe that I understand the evidence that it actually doesn't make a difference in terms of outcomes. And these focus groups what we did was we gave hypothetical case scenarios, and out of the 18 scenarios that we presented to the physicians, there was not one comment about asking the patient what they wanted or what they preferred. And I'll get back to that in subsequent slides. The other thing that seems to be happening is that physicians don't seem to be fully informing patients during the decision-making process. So this is a study done by Michael Rothberg down at Cleveland Clinic, and what they did was they took audio tapes of encounters between physicians and patients, and they coded them. This is for stable coronary disease, and they used a framework by Clarence Braddock, where the Braddock identified 7 elements of informed decision-making. And basically they did a yes-no, was this element present or was it absent? And in talking to Dr. Rothberg, he said, we were pretty liberal about whether something was present or absent. And here are the things that the framework discusses. So, was there any discussion that this was about the clinical issue and that this was a decision to be made? Were alternatives discussed? Were pros and cons of the alternatives discussed? Were the uncertainties of the decision discussed? Did the physician assess patient understanding in some way? And did the patient did the physician ask whether the patient had a role in what the patient's preferred role in decision making was? Was there any exploration of the patient preference? And then a composite measure of all 7 elements. And you can see here that people are pretty good about saying this is the clinical issue and here's the decision to be made. They, are not bad at doing pros and cons and assessing patient understanding. But if you look at, talking about alternatives and exploring patient preferences, maybe half or less than half of physicians did that in the encounter. And then very, very few, and that's the orange bar, very few had all 7 elements present. So you can see that the conversations often are not very rich in terms of all the things that you would think somebody should know and somebody should discuss before making a decision. But if you ask informed patients, it's unlikely that they'd all choose cardiac catheterization, which was the decision that was being studied. And so what they did further then was then look at the data and correlate it with who ended up getting catheterization. And you can see that if only one element of the informed decision-making scale was discussed, almost everybody ended up going to cath and having a stent. But when you get down to the people who had a robust discussion about the risks, benefits, and alternatives, only 40% of those chose to have the invasive procedure. And so I think what this is demonstrating is that, and it's very consistent that the more information you have, the less likely you are to want the invasive procedure. Now, this is not true for all decisions, but at least for this one, I think the inference here is that, when patients understand what the actual benefits are and what the risks are and what benefits they may be getting from it, and in fact, if the benefits are small, they may not want the invasive procedure, at least not right off the bat. So, I think what we can see here from the data that I presented is that physician-dominated decision-making leads to patients getting care even if there's little or no benefit. And the patient perspectives are not explicitly being taken into account. So these decisions may not, in fact, reflect actual patient preferences. If we, in fact, even know the actual patient preferences, that's another sort of hole, is that, if we don't ask the patient preferences, how do we know what the patient may prefer? And there's likely little shared decision-making taking place. And I think that's one of the issues of how do we measure whether shared decision is taking place, because these weren't actually direct measures, but the fact that not the things that were discussed, the things that are supposed to take place in shared decision-making encounters weren't discussed, I think is an indication that not much of it is taking place. So then that begs the question, which is what a lot of my research has centered around, is how do we get there? How do we make sure that evidence-based patient-centered care is being practiced both at the physician level but also at the system level? And so I'm going to use the case of elective percutaneous coronary intervention, which is coronary stenting, as the example. So, there's a huge push for evidence-based medicine, right? I think we all want to believe that we have gathered all this evidence, we've done all these clinical trials, and that we, if we practice according to guidelines and according to the medical evidence, that we're going to give good quality care. It turns out that guidelines and evidence may not be enough. So I think there's a very old study that cites 17 years as the time it takes from guideline publication to actual full implementation in care. So it takes a long time. And even landmark studies take a long time to diffuse into care. So this is the COURAGE study, which was a landmark study published in 2007 that looked at patients with who are not having a heart attack with stable coronary disease who were offered medical therapy, who were randomized to medical therapy, stent, and CABG if appropriate, and found that there was no difference in terms of mortality outcomes in this between the medicine and stent group particularly. And you can see now the orange bars are pre-study, and so this was a landmark study that that made a huge amount of splash in the cardiology literature, and all cardiologists basically know about COURAGE. So you can see that orange bars are pre-COURAGE, and the green bars are post-COURAGE, and there's basically not much movement at all. Pre-2007 and post-2007. I think they looked through 2009 or 2010 data. So really, even with this lot of press, landmark study, everybody knows about it, there's not much movement in terms of how care was changed. So unfortunately, just having that evidence is not enough to change care. So the cardiology community has actually been pretty forward thinking about how do we change care, and they have begun to publish what are called appropriate use criteria, and that's where they gather experts and they decide on, based on the evidence and where there's no evidence based on expert opinion, what are the appropriate indications for certain treatments. So this is for elective PCI. They have three categories: what they consider appropriate, what they consider clearly inappropriate, and then the center category of uncertain, where there's a lot of gray area and the evidence doesn't really tell us. There's probably a lot of individual patient characteristics and maybe preferences that go into whether something is appropriate or not. And you can see here over time that after the publication of the appropriate use criteria, that in fact the number of appropriate PCIs has increased, the number of inappropriate ones have decreased, and the number and certain ones have decreased a little bit. Now, which seems like good news, right? Except that if you look at the appropriate use criteria, a lot of it is expert opinion, and a lot of it is very vaguely written. So you can, interpret it in a lot of different ways. And then anecdotally, so when these appropriate use criteria came out, a lot of hospitals said, great, we're going to use this for judging whether something's appropriate or not. And so physicians basically gamed the system in a way and started, basically describing things. So for example, it says if you have a significant stenosis, and by significant on cath, that's about a 70% narrowing of the artery. But cardiac catheterization is a two-dimensional picture of the coronary arteries, and how narrow it is actually a fairly subjective opinion. And so anecdotally, we heard cardiologists say, oh yeah, so if I really want to do the procedure, it's 70 or 75%. If I don't, it's 60 or 65%. Or there's a technique using ultrasound that is actually makes the narrowings, because you get a 3D picture, often makes them less severe. So, the cardiologists say, well, if I don't really think I want to do that, we use the ultrasound and demonstrate that it's a little bit less severe. But, if it looks like it needs to be, I need to put a stent in it, we don't do that. And so those are ways where even the appropriate use criteria, even though they're, I think, they're in the right direction, those can not always reflect accurately the care that's taking place either. And there's also a lot of variation. You can see on the right here, this is hospital volume. And even though overall the mean volume has decreased, you still see pretty large confidence intervals. And so there's a lot of variation. There's still some hospitals that are doing a lot of elective stents. And so in this slide to show you just the level of variation that takes place at the hospital level. So you can see some places the blue bars, which is appropriate, are much larger, and some places white bars, which is appropriate, are much larger. And in hospital number 1, way on the left, the blue bar, which is inappropriate, is much larger. So there's still a lot of variation taking place. So even things like guidelines and appropriate use criteria are also not enough. I think that one of the things that I and others have tried to argue is that, even with all the evidence, treatment of stable CAD should be what we call a preference-sensitive decision. So clearly there's a lot of gray area. It's not a everybody should get it or nobody should get it kind of situation. You can think of decisions in medicine where there's not a lot of room for patient preference, or patient preference is not something that is very important. So if you break your arm, I don't think anybody's going to say, well, we should find out if the patient wants this casted or not. But when there are alternatives and when the evidence isn't clear and the benefit and there's a risk-benefit ratio, then these decisions should be preference sensitive, where the patient preferences should play into what the appropriate decision is. For example, in this case, if someone's not having a heart attack, but they're having angina symptoms, how you treat somebody who's 55, really active, runs 2 miles and says, I can't run my 2 miles because I get chest pain, versus somebody who's 85, has lots of comorbidities and gets chest pain when he walks a few blocks, but he's okay with that, and he doesn't walk a few blocks very often, and doesn't really want an invasive procedure. That ought to play into decision making as well. I think the trick here is, so how do we incorporate this? How do we make sure, and how do we study and measure the fact that that the patient's preferences are actually being taken into account? And that's what I've been working on for the past few years. So the current state of quality measurement is I think if you ask people, it's overwhelming in some ways. So there are too many. The NQF, the National Quality Foundation, has endorsed over 600 measures. And the Centers for Medicaid and Medicare has over 270 measures in their merit-based incentive program. So you can see, if you're a physician, and not all of them apply to your patients, but you can be really easily overwhelmed with how many things you're being measured on. And the U.S. spends an estimated $15 billion on reporting quality measures, and we don't even know if these quality measures, are the right ones that are telling us whether we're providing high quality care. The quality measures are often focused on what we can or is easy to measure. So the EHR, I think, and claims have driven that. So it's much easier and less expensive to extract data from the EHR and or from claims to measure whether something is happening or not, rather than collect patient-reported outcomes. That can be very expensive and very difficult. There's a danger of some ceiling effect of some measures. So one of the quality measures early on was everybody who leaves the hospital after a heart attack should get an aspirin. Well, now 99% of people get an aspirin when they're discharged. So does that really differentiate one hospital from another if 99% of the patients get it? Well, no. So it's not really actually a useful quality measure anymore. And then there's often no evaluation of value. For the example, so we don't explicitly often figure out, well, how valuable is this in terms of cost, in terms of value to the patient, in terms of value to the system? Is this something that we're getting our money's worth for, or we're providing some actual value to the patient? And that's in a lot of the quality measures, that's not explicitly asked. A lot of quality measures also don't capture the complexity of the clinical decision-making process or individual procedures. So it's often a yes/no. Did you get your colon cancer screening? Yes or no. Did you get your mammogram? Yes or no. It doesn't account for the fact that you're 55 years old and you have a really high risk of breast cancer because three members of your three first-degree relatives have had your cancer. So it's actually critically important that you get a mammogram versus if you're 70 years old and you have comorbidities and your life expectancy is less than 10 years, you're probably actually, even though the guidelines say so, you probably actually shouldn't be getting a mammogram because it's not going to benefit you. And then, as I mentioned, they don't necessarily incorporate the patient perspective either. So nobody's asking the patient, would you like to be screened for breast cancer? The measure is screen, yes or no. So one of the problems with the current quality measures is actually encapsulated by Ralph Brindis, who used to be the president of the American College of Cardiology, is now at UCSF and actually one of my collaborators on this study. And he writes that patients may not select those therapies demanded by current performance measures, and clinicians who do a better job of following patients' preferences may inadvertently appear to be performing lower quality care. And that's important because a lot of the incentives now are based, there's pay for quality. So CMS has this whole setup where there's money on the table for providing for meeting these performance targets. And so, what we've set up is a system where we may not actually be encouraging people to incorporate patient preferences and to have these discussions because it's both easier and more highly rewarded to just do what the quality measure says you should do. The UK actually they actually had a quality measure, a redesign of their system where they actually implemented quality measures in primary care called the Quality Outcomes Framework, where they changed the salaries so that part of your salary was earned back by meeting these quality measures. And when they did an evaluation of the program, what they found was that there was incremental benefit, that people did better where they were being measured. But one of the unintended consequences is that the places where they weren't being measured, the performance actually got incrementally worse because there's only so many hours in the day. And so what people focused on was what was measured. And so I think that's one of the dangers of quality measurement. It's unintended consequences. We may actually be encouraging people not to do the right thing or not to have these conversations. So what we need is a method to measure whether patient-centered decision-making is taking place. So as I mentioned, we have evidence-based measures. So that's the measures based on the guidelines. We have whether something's clinically appropriate with the appropriate use criteria. And we have some patient-reported measures of quality of life, although those aren't necessarily always widely used. But we don't have a measure where we measure whether a patient was informed, whether their preferences were considered, and whether they're participating in the decision-making process to the extent that they desire. And this is what we term the decision quality measure. And this matters now, actually. So the Affordable Care Act, in its creation, called for all new shared decision-making programs, but down here at the bottom also called for quality measure development for shared decision-making, which identified a big gap in the way we create quality measures. So that the fact that it was explicitly called out in this legislation, I think, makes it really important that we actually focus some efforts on trying to create those quality measures. And as I mentioned, the quality of a decision should be based on how well the clinical evidence is incorporated into the decision-making, how well the patient's informed, and if values and goals are taken into consideration, and whether patients should have a desired level of involvement. So I'm not saying, I don't think we're saying that everybody needs to do shared decision-making, because that's clearly there are some patients who come in and they want the doctor to make the decision, and that's perfectly fine, but that ought to be something that's discussed instead of assumed. And then this is a key, this last point is a key one, is that there should be mutual endorsement of the decision by all parties. So it should be something where both the physician and the patient are comfortable with the decision, because we also don't want decisions where the physicians feel like, well, what's my role here? Because aren't we just supposed to listen to the patient? And clearly, the physician brings expertise, and so we want to recognize both the physician expertise and the patient expertise. So some of the challenges to measuring decision quality. So some of the tools currently available to measure the decision-making process aren't comprehensive, so they don't measure all aspects. So they might measure the patient's preference for decision-making. There's some scales there. They might measure, how the patient felt about the encounter. They might measure what the patient's perception is of how much they know. Others use observer scales. So there are a lot of well-validated scales out there that are, you're supposed to observe either by audio tape or videotape, or in-person observation, did the physician do this? Well, those, if you can imagine, when you're trying to implement that, that's almost impossible to implement on a large scale outside of a research study. You're not going to have an observer in every clinical encounter trying to rate whether or not high-quality decision-making took place. It's also very difficult, as you can imagine, to measure patient values. Values may change over time, so at what point do you measure the values? And values can be culturally specific. So what someone might value in one culture is different from another. And then implementation is difficult, partly from a systemic point of view, because there are competing priorities on the systemic level. So in the case of cardiology, the reimbursement, you get reimbursed for what you do, not what you discuss or what you think. So you get reimbursed for doing the procedure. You don't get reimbursed or you get reimbursed much less, because you can code on time, for having an hour-long conversation with the patient about what the risks, benefits, alternatives are, and what their preferences are. So all of those things make it sort of a difficult environment and a challenge to do this. So what we did was we set up a study to develop an instrument to measure patient-reported decision quality around treatment for coronary disease. And our goal is actually to develop something that can be used in routine care. So it's great to develop a measure, but if your measure is never used, it's not very helpful. So to do this, we tried to get the buy-in of a national network of stakeholders to think about implementation up front and setting up a national network so that we can facilitate implementation later. So one of the challenges of implementation is you prove something works at the local level, and then you have to try to implement it in different settings. So we are trying, so right now we have 4 sites around the country, San Francisco, 2 sites in Kansas City, one's a private hospital and one's a county hospital. Memorial, and then a University Hospital in Atlanta. And we're trying to make sure we have the broad spectrum of patients and broad spectrum of practices so that this kind of quality measure can work for everyone. Our steering committee is chaired by Dr. Brindis, who was the former president of American College of Cardiology, and we have some site PIs who have a lot of experience in this area. We also engaged an expert advisory panel of not just cardiologists, but primary care physicians, decision scientists, nurses, patients, all people who we thought would have both expertise and some interest in quality measure development and making sure this gets implemented. And then we had a separate patient advisory board to make sure that the patient, as this is a measure of patient-centered care, we want to make sure the patients have a role in shaping and making sure we're asking what's important to patients. And what our stakeholders told us is that the survey needs to be short, and they said a maximum of 10 questions, although as we've gone through, what we've realized is it's actually not the actual number of questions, but the time it takes you to do the survey. That's the important variable. So people, as long as the survey doesn't take them a long time, whether it's 5 questions or 10 questions, it doesn't make a huge difference. They told us that the survey needs to ask about patients' objective knowledge, so that it's not enough to ask people if they thought they knew enough, because often they don't actually know what they don't know, but that we needed to ask people objectively what they knew, that we needed to ask about communication between the physician and the patient, and that we needed to ask about, obviously, patient preferences. The physicians told us that this needs to be, quote, fair to physicians for buy-in, so it can't look like you are judging physicians and you're trying to make it seem like they're not doing a good job. They don't react well to that, as you can imagine. And the patients actually on the other side also said the patients didn't want to feel like they were judging the physician, because they had a lot of respect for their physicians. And the physicians also told us to avoid topics where the evidence is controversial, which is, makes sense. You don't want people saying, well, I don't agree with that part of the quality measure, and then ensuring that the information gathered will be useful to physicians. So that, is this something actionable? And I think that's a common theme in terms of quality measure development, is that you want to collect something that's actionable. Again, so what we did was we are trying to create questions that focus on the patient's decision-making process and experience, and not about quote, rating the doctor, because neither the physicians nor the patients said that would be a useful or acceptable exercise. So we went through a literature review and some item development, and we developed questions for three domains of decision quality that I mentioned: knowledge, communication, and preferences. And we did pretty extensive cognitive interviewing, where we recruited patients that fit our entry criteria into the study, and asked them, what do you think about when we ask the question this way? And do you understand what we're trying to ask here? And how do you interpret this question? Because it turns out even the simplest questions can be interpreted a number of ways, and you want to make sure you're actually capturing what you want, what you intended to. And then we also got feedback from our expert advisory panel and the patient advisory panel. So at the moment, we've completed a pilot test of 200 patients using a national network of centers, and that led us to revise the survey. So it turns out that especially the knowledge questions are fairly difficult to write that at an appropriate level. So we were aiming for the 6th grade level, which in some areas in our county hospitals actually were also, for some patients, was still too high of a level. So it was difficult, which is a bit difficult because we needed to use some technical terms like angiogram. There's no way to sort of get around that kind of technical term. But we did try to simplify and revise the survey based on all of that feedback. And what we also got, just in terms of feedback from our sites, is that the patients actually were really engaged, and they really felt like this was an important thing, that nobody had ever asked them what they thought about their experience or what they thought about this particular decision. That they get lots of surveys about, when you went to the doctor, how was the front desk staff, and, do you feel satisfied with your care? But nobody had ever asked them about that particular decision, and they wanted that voice, and they thought it was important to have that voice. So actually the patients who took the survey and participated so far have actually given us a lot of good feedback. We have just finished recruiting 400 plus patients for our larger validation study to look at psychometrics. And what we did was we surveyed stable coronary disease patients, non-ST elevation MI patients in the clinic and in the hospital. We also audio taped physician and patient discussions about treatment to compare, so that we could both compare the survey answers to the observer's evaluation of decision quality, but also we can also probe those tapes later on to say what actually happened. So one of the issues in trying to change care is that traditionally, physicians practice kind of in isolation. Nobody knows what goes on outside of the exam room. Nobody's in there listening to what the physician has to say, or often that's not feasible. So, what we did was we wanted to make sure that our survey reflected what's going on in care, because obviously we don't want to be measuring something that isn't relevant. And then we have some comparison of the measure with other validated decision-making measures. So all that, we just actually finished recruitment, so we haven't had a chance to analyze all the survey data yet, but we did analyze our pilot test data. And what we found may not surprise you based on what I've already told you, but still was a bit. The numbers, I think, are show us how far we have to go still. So this is we're looking at patients' preferences for decision-making versus how decision-making occurred. So we asked patients, one of the questions is, how do you prefer to make your decision? And the options are, I prefer to make it alone, I prefer to make it alone after hearing recommendations from the doctor. I prefer shared decision-making, making the decision together with my doctor. I prefer my doctor make the decision after consulting with me, and I prefer making the doctor making the decision, and I don't want to have any part of the decision-making process. And you can see here the vast majority of people wanted to do some level of shared decision-making. But when we actually asked them what was discussed in the encounter, and that's whether they were offered one of the three options, medical therapy, PCI, or cabbage, you can see that there's tremendous variation. So only 42% of patients said that they were offered medical therapy as a choice. 73% said they were offered PCI or stenting, and 29% said they were offered cabbage. So you can see just roughly, not a lot of people weren't offered more than one option. And then almost 20% of patients felt like, whether this is true or not, we'll have to go back to the audio tapes, but they felt like they weren't even offered a choice, that the physician just said, this is what we're going to do. And so that you can see that differs from the 9% who want the doctor to make the decision. So clearly there's a gap there that we need to do better about both ascertaining and then intervening on. And then when we asked them about preferences to treatment and then compared that to the treatment received, there's an even bigger disparity. So we asked them, do you prefer, and we asked these in separate questions, do you prefer medical therapy over PCI? Do you prefer PCI over medical therapy? And do you prefer cabbage over PCI? And you can see that, a large proportion of patients, 47%, said we prefer medical therapy over PCI, but 71% of the patients ended up getting PCI. So clearly something is going on there where there's some disconnect of what patients say they might want and what's actually happening in care. And so we're hoping with this larger study that we can validate our measure and probe deeper and get some more information about why this is happening. So some of the challenges that we are facing implementing something like this is, one is the difficulty of culture change. So one of our physicians told us, it's not the patient's decision. They don't know enough to make the decision. This is someone we were trying to recruit to help us recruit patients for our study, and clearly he didn't agree, but he basically said, I don't think there's a role for the patient in this decision, which is concerning, to say the least. But he's out there practicing, and he doesn't get penalized for that. He doesn't, patients go to see him, and nobody's out there saying, hey, wait a second, maybe the patients do have a voice. The other thing is many physicians believe that they're already practicing shared decision-making. So in another study that we did, when we were implementing decision aids into primary care, we did some focus groups and surveys. And in the survey, we asked, how much of the time do you think you're doing shared decision making? Some of the time, a little time, over 50%, most of the time. And I think about 80% of the physicians said, oh, we do shared decision making like most of the time. Which, if you look then at all the data out there about when you actually observe the encounters, that's probably not the case. And so if a physician already thinks that they're doing shared decision making, well, why do they need this decision quality measure, and why do we need to make changes in care? So we're sort of facing that headwind. And then the other things that we're working on is finding the appropriate time to survey patients. So it's much easier to survey patients after the encounter is done, and you can just either give it to them on their way out, or you can mail it to them 4 weeks later. That's much cheaper than trying to find the time at which they've made the decision, but before they've had anything done. So one of the issues is that the outcome can often influence how you feel about a decision. So the optimal time may be right after you made the decision, but before you actually had a procedure. That time is very short and might not be feasible. So what we're looking at, one of the things we're looking at is timing of the survey, as whether we do it pre-procedure or post-procedure, does that change people's perspective? As I mentioned earlier on, there's also competing demands on the physician time and the patient time. We often have patients say, I'm really interested, but I don't have time to fill out the survey. Or I'm sure you've all gotten surveys in the mail where you say, I'm going to do that later, and it just never happens. And then finding the appropriate partners for implementation. When you're implementing something, you obviously can't do this nationally right away. So who are sort of the leaders that we can tap into who will have influence and help us implement this? And I'll just end with, where might this lead? And this is sort of the health services research brain of it. So there's the sort of the practical implementation and improving care, but also, the question is, does better decision quality lead to improved outcomes like better patient adherence? Maybe if the patient feels like they've had some skin in making the decision, that they'll adhere better to the medications. Does it improve? Does it lead to cost savings? Does it decrease health disparities? So maybe one of the issues is that if we are able to bring the patient into the conversation, that patients who are for whom there are disparities, that might actually get smaller because they're able to express, what their preference is and get the information that they need if we're measuring this. And then, can interventions lead to better decision quality? Can we actually is this actually actionable? Can we do things? And then identifying which patients need the most help with decisions. So one of the things that you can imagine is up front, you could use this actually not just to judge decision quality, but to help the physician. So maybe you give them this decision quality survey before they come see the physician, and the physician can see, oh, well, you didn't know these knowledge questions you didn't know, so we need to focus on, making sure you know these things so you can make an informed decision. And then, oh, I see that your preference is actually medical therapy. Let's explore that a little, and let me tell you and make sure you understand the benefits and risks of that decision. So this, I think, this model could there's some interesting questions to be answered, and better decision quality actually may be a goal in and of itself, and it probably is a goal in and of itself, but it actually also may have implications down the line for utilization. So just to wrap up, I think, hopefully some of the things I've showed you today is that care is not always patient-centered, that the evidence suggests that the decision-making process is not always consistent with preferences, and that the evidence suggests that current treatment is not necessarily what would happen if we improve decision quality. Our current approaches to measuring care don't include the patient perspective. And then we are in the process of developing this measure, and hopefully in the next few months, next year or so, we'll be able to say, this is validated, and start the implementation process, and try to push the needle towards better quality measures that actually measure how care is being delivered and whether care is patient-centered. So just some acknowledgments of our partners and funding, and I'm happy to take questions. Thank you for your attention. Yes.
So, almost everybody would say if there's a difficult decision to be made about your life, you would want to be involved in making that decision. But really what we want is for there not to be a difficult decision, right? I mean, when I go, when one of my family members gets sick and we go to the doctor, we really want to know that the course is clear, and, I think there's some pretty good evidence from sort of looking at public policy experts and public intellectuals that people who are more definitive in their opinions are seen as more expert than people who are more nuanced and honest, perhaps. Yeah, so it would be interesting. I think one line of research would be to sort of try to unpack a little bit of what patients are saying when they say they want to be involved in these decisions a little more, and how physicians, because of course, as physicians, probably second only to our interest in trying to further our patients' interests is preserving our expertise and our reputation. So, what's the point of being an expert if you don't feel like people perceive you as an expert and you're seen as knowledgeable, right?
Yes.
And to do something that seems to be every day undermining how people are perceiving your expertise, that's going to be a non-starter, right? Mm-hmm. Nobody will do it.
Right.
So, but it seems like there would be ways to kind of test this and look at it, by, having patients kind of look at different people explaining a clinical scenario and seeing how they react to it, and that would be really useful for trying to help physicians feel that they can do this without undermining their expertise.
Yeah, that's a really good point. I think, like I said, physician, acceptance is a big challenge, and I don't think we set out, and part of the reason that we have so many stakeholders, and we're trying to make sure that is reflected in the physician perspective is reflected in the measure, is because we're worried about that we're worried about that the physician is going to say, well, why bother? You're basically, like you said, undermining my expertise. I think that's not the goal of this. I think, one of the issues, and one of the things that I think we've thought a lot about is trying to figure out how can this help the physician, and at least in primary care, and I don't know about specialists, but at least in primary care, I feel like there's not enough time. And if somebody is going to help me have a better conversation with my patient, that's going to be helpful to me. And so, I think the focus here is how do we have better conversations, and that's the way we've been sort of we've been approaching this, is how do we help physicians and patients have better conversations about these decisions. I agree with you that people want things definite. They want definite directions, but the truth is that medicine is not, always clear. And I think we probably pay a disservice to ignore that uncertainty, and ignore the fact that things are uncertain, and we need to be better about educating our patients that there is nuance. But I agree with you that actually, and it's a great suggestion about trying to figure out when patients are saying, this is what we want, what they actually mean, because I suspect that 85% who say they want shared decision making, they don't all want equal 50%, 50%. Some of them want, for some of them, shared decision making means the doctor asked me what my opinion was and then told me what he recommended. And for others, it's, I want to know all the information and make this mutual decision. So I think that's a great suggestion. Thank you.
Hi, thanks for your talk. It was great. I would add on to that point that I think that some of the times that where the patients and families need help is helping know what matters most to them. So if it's, I'm a runner, or, whatever the case may be, that there are options. You want to have the clear path, but you also want to understand the implications. So sort of patient-centered outcomes versus just better medical outcomes.
Yes.
You know what I'm saying? So
Yeah.
I think that's part of the equation, which is a little more delicate too.
Yeah, no, that's a great point. I think there's a push towards collecting patient-centered outcomes, and I think we're just not there yet in terms of having those data available. There's some quality of life data, but often that's missing, and so you're right. We need to do better at that.
Great talk. What has your experience been with funders around this topic? Especially as we take shared decision making and sort of transpose it from maybe where it originally resided into areas of sort of we're trying to resolve areas where there may be clinical uncertainty, there's insufficient data, maybe to guide what we ought to do. One area of pushback that we've often gotten is, hey, we just need more data in this area. This is not a place where how a patient's going to know what to do, et cetera. Have you gotten comments like that, and what has your experience been?
Yeah, that's a good question. So yes, we have gotten comments like that. This study was partly funded by MyK, which is funded by ARC, which is a little bit friendlier, I think, in terms of that. But it's also funded partly by NHLBI. And we were actually a bit shocked that NHLBI was willing to fund this. But I think that there's beginning to be recognition that this is an important area. And that I think the frustration that the funders have had is that they feel like shared decision making, like it's not novel. And so I think what we did in this study was to try to demonstrate that there is a lot still to be done, and the quality measurement of it is a novel place because not a lot of work has been done in that. So I think what the funders have been looking for is sort of that novelty of not just, here I've developed a decision aid and I'm going to implement it, but what is it? How can we move the needle beyond just shared decision making, just decision aids? Yes.
Thank you for such a thought-provoking talk. My question really is actually a few comments and a question. The first is that decision-making often occurs in these acute and non-acute scenarios, and as such, emotions play into that decision-making process. The NCI has an RFA looking at emotions and decision-making, and I'm just wondering to what extent your team is actually measuring that on both the patient and provider side of the equation.
That's a great question. We actually haven't focused on that at all in terms of measuring that. We decided just for more practicality reasons, because there's only so much you can put in a survey and measure, that we left that part out of it. We do have these audio tapes though, and I think that's one of the things that we ought to look at is kind of when we're listening to these audio tapes, kind of trying to gauge that a bit. But we haven't measured it directly, and I appreciate the comment and pointing out that that's another avenue for research.
In your development process for the measure, you mentioned that one of your steps after your pilot test was reviewing with other decision-making measures that are already validated. Could you mention some of those which are already validated for patient preference capture? Sure.
So we actually on our survey we actually have the decisional conflict scale, which is validated. Although it's I think and I'm hoping that our study bears this out, that it's actually a little decisional conflict is actually a bit of a different concept than decision quality. And then Karen Sapuka at Mass General has a decision quality instrument where she has a section on patient preferences, and so we're comparing to that. And then we're comparing to the Collaborate scale, which is a generic scale from Glenn Elwyn about shared decision making. And then the other one we're doing is decision regret, actually, with the idea that if we have a higher quality decision, is there going to be less regret later on? And so those are the measures that we're focused on.
Yeah, well, great. Thank you very much, Grace.
Thank you.